section is diarrhea in the pediatric age group. Diarrhea. Now, diarrhea can be divided into infectious, and non-infectious causes. Non-infectious causes. I've discussed most of the infectious causes in the section of internal medicine of infectious diseases, but regarding the pediatric causes of infectious diarrhea, the most common infectious cause of diarrhea in the pediatric age group is the rotavirus. Rotavirus is the most common cause. And other viruses such as Norwalk virus, and gastrointestinal adenovirus or enteric adenovirus is also one of the common causes of diarrhea. So in most of the cases in infants, the diarrhea from infections due to infections is due to viruses, and the most common virus that causes diarrhea in infants is rotavirus, which is the only virus which has a double-stranded RNA. And these viruses can be detected in the stools by doing enzyme immune assays. So these viruses can be detected by enzyme immune assays which have been developed. Various non-infectious causes of diarrhea also can exist in children, and these non-infectious causes can include antibiotic therapy. Antibiotic therapy can cause diarrhea in patients, and also other causes I've already discussed in the section of internal medicine. Regarding chronic diarrhea, these are the causes of acute diarrhea. Chronic diarrhea can also occur in children, and the most common cause of chronic diarrhea that in children is secondary lactase deficiency. Secondary lactase deficiency. Lactase is a disaccharidase enzyme that is present on the brush border of the intestine, and due to viral infections, for example, infections with rotavirus, Norwalk virus, or adenovirus, multiple viral infections or multiple diarrheas, this enzyme can be lost from the brush border, and due to this there is secondary lactase deficiency. Lactase deficiency occurs due to which they have chronic diarrhea. So chronic diarrhea can occur due to lactase deficiency. It can also occur due to milk intolerance or soy intolerance. Milk or soy intolerance can also cause diarrhea, chronic diarrhea in infancy. In addition to that, celiac disease, inflammatory bowel disease can also be a cause of diarrhea in infants, and cystic fibrosis is also an important cause of diarrhea, chronic diarrhea in infants. So these are a few causes of chronic diarrhea and non-infectious diarrhea, and the other causes in older children and adolescents are similar to those that I have already discussed in the internal medicine section of infectious diseases. So after diarrhea, I'll be discussing the other extreme, that is constipation, which is infrequent passage of hard stools, infrequent passage of hard, dry stools. That is what is constipation. Constipation most commonly in children is due to a functional cause. Functional. What I mean by functional is that the children retains stool in their intestine voluntarily. There is voluntary withholding of the stool, which is the most common cause of constipation in children greater than 2 years of age. This cause occurs in greater than 2 years of age. The most common cause of constipation in a neonate, or the cause that should be considered first of all in neonates, if a neonate presents with constipation, is Hirschsprung disease. Hirschsprung disease. In Hirschsprung disease, what happens is that there is defective migration of the neural crest cells during the embryonic life. There is defective migration of neural crest cells in the gastrointestinal tract, which results in deficient ganglion cells within the myenteric plexus, and it is the myenteric plexus which is responsible for the motility of the stomach, the motility of the intestine. So when there are no ganglion cells within the myenteric plexus, there will be constipation. And the segments of intestine that are most commonly involved by Hirschsprung disease are the rectum and the sigmoid colon. Rectum and sigmoid colon are most commonly affected by Hirschsprung disease, and this cause should be considered in every neonate that presents to you with constipation. But the most common cause of constipation in children is functional constipation. Now, how do these patients of functional constipation present to you clinically? Well, these patients present to you with constipation, obviously, and in addition to that, they can also present to you with encoparesis. Encoparesis, which is stool incontinence, leakage of stool from the anus, leakage of stool. And how does this occur in constipation, functional constipation? Well, what happens is that in functional constipation, there is hard stool, and around this hard stool, there is some soft liquid stool that forms. Soft liquid stool around the hard stool, and this liquid stool cannot be retained by the child, and the child develops encoparesis. Functional constipation is usually clinically diagnosed, and it usually does not require any treatment. It resolves by its own, and this functional constipation is usually due to forced toilet training in childhood, in infancy. Forced toilet training, and all you require in these patients is simple reassurance. Hirschsprung disease is diagnosed by a rectal biopsy usually, or biopsy of the involved segment of the intestine. Also, when you do an X-ray of the abdomen or you perform a barium enema, there will be massively dilated portions of the colon proximal to the segment which is aganglionic. Massively dilated colon or massively dilated intestine will be observed. And in Hirschsprung's disease, the cure is surgical. You have to remove that aganglionic segment of the colon. In addition to all these causes, other causes of constipation that must be considered in infants are infant botulism. Botulism is a cause that can be considered, especially if the infant is taking honey. If the infant takes honey, because honey can contain spores of this bacteria, Clostridium botulinum. Cystic fibrosis patients can also present to you with constipation. Cystic fibrosis, as I mentioned, can present to you with diarrhea, and it can also present to you with constipation, especially if in a neonate, when a neonate is born, after birth, the neonate can present to you with meconium ileus, that is failure of passage of meconium within the first 24 to 48 hours. So cystic fibrosis can be a cause that should be considered. And also, you might not find any cause you might do all these laboratory investigations, you might take a good detailed history of this patient, but if you fail to examine a neonate properly, you might miss an imperforate anus. Imperforate anus. Actually, these children of imperforate anus are not constipated. They cannot pass through because their anus is imperforated. So a clinical examination, a thorough clinical examination is valuable in these cases. Always do a thorough clinical examination so that you do not miss any obvious findings. So that is all about constipation in children. Functional constipation occurs in greater than 2 years of age, and Hirschsprung disease occurs in neonates. Functional constipation is the constipation in which there is encoparesis, and it is associated with forced bowel training. And when you do digital rectal examination or you observe the rectum in functional constipation, the rectum will be full of stool. In Hirschsprung's disease, the rectum will be empty of stool, and it is confirmed by Hirschsprung's disease is confirmed by rectal biopsy, and functional constipation, usually a rectal biopsy will be normal. The rectal biopsy definitely will be normal. So that's all about constipation. Now I'll be talking about another topic, which is GI bleeding in children. Pediatric causes of GI bleed. GI bleed, as you know, can be divided to upper and lower GI bleed. Upper GI bleed is the one which occurs proximal to the ligament of Treats. Ligament of Treats is located at the duodenojejunal junction. Duodenojejunal junction, proximal, any bleeding that occurs proximal to that is classified as upper GI bleed, and any bleeding that is distal to that is classified as lower GI bleed. But the causes of GI bleed differ with respect to age. If a neonate is born and presents to you with hematemesis, a neonate who presents to you with hematemesis, you should consider the cause of swallowed maternal blood. You should consider that the infant might have swallowed maternal blood during delivery. Swallowed maternal blood should be considered. Also, in infants less than 1 year of age, in children less than 1 year of age, gastritis is also a common cause. Gastritis can lead to upper GI bleeding in the form of hematemesis or melena or dark stools. They can also suffer from peptic ulcer. Infants less than 1 year of age can also have peptic ulcers as well. And malrotation of the intestine, malrotation and volvulus can also cause upper GI bleed. Malrotation and volvulus. These are the causes of upper GI bleed in infants who are less than 1 year of age. Lower GI bleed can occur in infants less than 1 year of age, and the most common cause of lower GI bleed is acute anal fissure. Acute anal fissure, which occurs in children of this age group due to constipation or due to attacks of diarrhea, explosive attacks of diarrhea, which cause acute anal fissure, which leads to lower GI bleed. Another cause that can lead to lower GI bleed is intussusception. Intussusception, which I'll be discussing later on in the course of this chapter. Necrotizing enterocolitis is a cause of lower GI bleed that occurs in a newborn who is premature, and it can be diagnosed by not only by examination. You have to suspect that this patient is premature, this neonate is premature, is susceptible to necrotizing enterocolitis, and when you do an abdominal X-ray, the classical characteristic pathognomonic finding will be air within the wall of the intestine, which is called as pneumomatosis intestinalis, which will pretty much confirm the diagnosis, and the treatment is surgical. Also, malrotation and volvulus of the lower GI tract can also cause lower GI bleeding. So these are a few causes of upper and lower GI bleeding, common causes of upper and lower GI bleeding in infants who are less than 1 year of age. If the child is greater than 1 year of age, the causes differ slightly. In that case, upper GI bleed can occur due to peptic ulcer, due to gastritis, due to esophageal varices. Variceal bleeding can also occur in infants greater than 1 year of age and have to be considered in the differential diagnosis. These are the causes of upper GI bleeding. Lower GI bleeding in infants, in children who are greater than 1 year of age, can be due to colonic polyps, can be due to polyps, and this is a pretty frequent cause of bleeding in children who are older than 1 year of age. Also, intussusception is an important cause of bleeding greater than 1 year of age, although the majority of the cases occur between 6 months to 1.5 to 2 years. Older children can also rarely suffer from intussusception as well. Meckel's diverticulum, or Meckel's diverticulitis is an important cause of lower GI bleeding, and characteristically these patients present with painless lower GI bleeding. I'll be discussing that a bit later on. Infectious diarrhea is also an important cause. Infectious diarrhea with, for example, organisms that invade the gastrointestinal tract, which cause damage to the intestinal epithelium, such as E. coli, enteropathogenic enteroinvasive E. coli, Shigella, and various parasites, for example, amoeba histolytica. Entamoeba histolytica is a cause of diarrhea, dysentery in children, but it is rare in the United States, more common in the developing part, underdeveloped or underprivileged world. Inflammatory bowel disease is also an important cause with Crohn's disease, and ulcerative colitis can also lead to lower GI bleeding. So these are a few causes of upper and lower GI bleeding in children. I've already discussed inflammatory bowel disease in internal medicine, so I'll not be going through that. I'll be discussing a topic in GI bleed which is very important for you, and which is intussusception. Intussusception is basically defined as invagination of the proximal bowel into the distal segment of the bowel. The bowel invaginates, the proximal segment of the bowel invaginates into the distal segment, and it most commonly occurs where a small part of the bowel, such as the small intestine, joins the large intestine. So ileocolic type of intussusception is the most common. Ileocolic, because ileum is large and ileum is small and colon is large, so the ileum telescopes through the colon, and intussusception can occur in that case, and the most common cause and the most common type is ileocolic. How do these patients present to you clinically? What are the clinical features? Well, the most common age group for intussusception is the infants, infants less than 1 year of age, and this disease commonly occurs in 6 months to 24 months of age. 6 to 24 months of age is the most common age group for this intussusception to occur. These children present clinically with recurrent bouts of acute abdominal pain. If an infant cannot express himself or herself, then these infants, for example, an 8-month-old infant presents to you with intussusception. How will this 8-month-old infant present to you? This infant the mother will tell you, the doctor, my child cries all the time. From the past 2 days, he has been crying, and all of a sudden he develops an attack of crying in which he flexes his legs towards his body and clenches his fists, and then this lasts for 2 to 3 minutes, and then for 10-15 minutes he's asymptomatic, he does not cry. After that, there are intermittent episodes of crying, and that is how the children will present to you. Intermittent episodes of abdominal pain, and these children will present to you with intermittent episodes of abdominal pain, and the infant will present to you with crying, intermittent episodes of crying. In addition to that, you should also examine the patient for any associated disease. If a child is older than 2 years, for example, if a child is older than 2 years and presents to you with acute abdominal pain with palpable purpura, you should consider the diagnosis of HS purpura. Henoch-Schönlein purpura has a high degree of association with intussusception. So if a child presents to you with HS purpura and acute abdominal pain, you have to also consider that this child could be suffering from intussusception. Another important association with intussusception is lymphoma. Patients of lymphoma can also have a high incidence of intussusception, have a higher incidence of intussusception. Patients who have Meckel's diverticulum are also at increased risk of intussusception because, again, there's a small portion of the intestine which telescopes into the larger portion and they develop intussusception. Also, patients with various infectious diarrheas are also at increased risk of intussusception. Another characteristic clinical finding along with abdominal pain is that these patients can present to you with lower GI bleeding. As I just mentioned, the causes of lower GI bleeding, they can present with lower GI bleed. And lower GI bleed, when it becomes mixed with mucus, gives the appearance of color jelly stool, current jelly stools. So these are called as, characteristically, they are called as current jelly stools. And this characteristic finding of current jelly stool is a late finding in intussusception. So you should not rely on this current jelly stool for diagnosis. You should have a high degree of suspicion in any patient who presents to you with intermittent episodes of crampy abdominal pain and so forth. So how do you diagnose this condition? This condition is can be diagnosed by a barium enema. Barium enema. Barium enema not only is a diagnostic modality, it can also treat the cases of intussusception. Also, air enemas. Air enemas can also be used to diagnose and treat intussusception. Ultrasonography can also be helpful to diagnose intussusception. So how is intussusception treated? It is treated by, number one, first of all, you have to try barium enema. Barium enema can be tried in most of these patients, and most of these patients will recover with a barium enema. If the patient presents to you with intussusception whose clinical findings have lasted for less than 48 hours, then they have a high chance of being cured by barium enema. That greater than 75 to 80% of these patients who present within the first 24 hours with intussusception will be cured by barium enema alone. But if the child presents to you in greater than 48 hours, then the cure rate progressively declines to 50%. Only 50% will be cured. If the child is cured by barium enema or an air enema or hydrostatic reduction, then you do not require any surgery. But if this fails, then surgical correction may be required. Surgical correction is required in those cases if there is failure. So that is all about treatment of intussusception. These patients can present to you. The most dreaded complication of intussusception is, number one, it is intestinal obstruction, but more serious than intestinal obstruction is that these patients can present to you with strangulation of the bowel, loss of blood supply of the bowel due to telescoping of the gut. The blood supply of the gut gets compressed. They can present to you with strangulation. So you should avoid these complications by urgent treatment of these children. So, after intussusception, next I'll be talking about a congenital abnormality, which is Meckel's diverticulum. Meckel's diverticulum. Meckel's diverticulum is a diverticulum which occurs on the anti-mesenteric border of the ileum, anti-mesenteric border, and it is a congenital diverticulum, and it is also called as disease of Touze. It is also known as the disease of Touze most commonly. You must have read this in many books, that is called as the disease of Touze. The reason being that this is a pretty good mnemonic for memorizing the features of the disease. 2%, it affects 2% of the general population. It is 2 feet proximal to the ileocecal junction. It is 2 inches, usually 2 inches in size. It occurs 2% of population, 2 feet proximal to the ileocecal junction, usually 2 inches in size. And it can contain two types of epithelia, the gastric and the pancreatic epithelia. If the gastric epithelium is present, these patients can present to you with a peptic ulcer disease in the diverticulum. So they can have two types of epithelia as well. So that is the reason why it's called as disease of twos, just for you to memorize it so that you can memorize it easily. Meckel's diverticulum, by the way, is the most frequent congenital abnormality of the gastrointestinal tract. How do these patients of Meckel's diverticulum present to you? Well, if a patient has a Meckel's diverticulum, and he can present to you in an asymptomatic way, you for some reason investigate this patient for some other cause, you find a Meckel's diverticulum, so they can be asymptomatic. But if they present to you with a symptom, the most common symptom is painless lower GI bleeding. Painless lower GI bleed is the most common symptom in these patients. Painless lower GI bleed. If this Meckel's diverticulum becomes inflamed, just like that, just like appendix, these patients can present to you with Meckel's diverticulitis, with abdominal pain in that region. These patients can also present to you with intussusception, which is a complication that can occur in these patients. Intussusception can also occur, and these patients are diagnosed by technetium scan. Technetium scan is the most sensitive test for the diagnosis of a Meckel's diverticulum. Most sensitive. How is it treated? It is treated by surgical removal of the Meckel's diverticulum. Just as you have removed the appendix, you remove the Meckel's diverticulum and the patient will be alright. So that is all about Meckel's diverticulum. Now I'll be talking about a syndrome. It's called as the Reye syndrome. Reye syndrome. Reye syndrome is basically an encephalopathy that is associated with fatty degeneration of the liver. The exact cause of Reye syndrome is unknown, but it is an encephalopathy which is associated with fatty degeneration of the liver. It is an acute disorder which occurs which is preceded usually by a viral infection. It occurs in children, it occurs in the juvenile age group, it occurs in children of 5 to 6 years of age. The peak age of onset is 5 to 6 years of age, but it can occur in children from 4 to 12 years of age. The children usually present with a preceding viral infection, and their mothers usually give them aspirin for the relief of fever. And after giving aspirin, these patients develop confusion, they become confused, they become lethargic, they can go into a light coma with decerebrate posture, decorticate posture, they can go into a deep coma with decerebrate posture, they can go into flaccid paralysis. So it depends upon the severity, the clinical features depend upon the severity of the encephalopathy that occurs in these individuals. So it is most commonly it is associated, an association has been made with preceding viral infection, and its incidence is increased in those individuals who have been given aspirin, those children who have been given aspirin for the relief of fever. But the exact cause is unknown, but it has definitely been demonstrated by experiments, by observations, that if you do not give aspirin in patients who develop a viral illness in children, the incidence of Reye syndrome is greatly reduced.